So, hello everybody, and thank you very much for being with us this afternoon. Um, Today, we're having Dr. Rameau from New York City, and she's going to talk to us about the whatever happened to reflux. And I think this is really a uh, uh, very good statement because, for a long time, we kept on hearing about reflux being causing this and reflux causing that, and all of a sudden, uh, nobody talks about reflux anymore. So, Dr. Rameau, can you hear me?
Yes, can you hear me?
Absolutely. Thank you very much for joining us. That's
Thank
great.
you so much for your invitation, Dr. Tarabishi.
So tell me again, you went to medical school at McGill or residency at McGill?
I went to medical school at McGill. That's where I fell in love with ENT.
All right. Okay.
Yes.
We had an earlier communication on the email because I did my residency at McGill and she brought that up. So thank you again. I don't want to waste much time. You have the podium.
Okay, sure. Let me make sure I can share my screen.
Yep, that's great.
Let me just have the presentation slide. 1 second. All right. Good morning or good evening, everyone. It is 9 a.m. in New York City. And today I'll be talking about whatever happened to reflux. And really the focus will be on laryngopharyngeal reflux because as otolaryngologist, as Dr. Tarabishi mentioned, that has been a big bulk of the past few decades of research in various subspecialty of ENT. I have a few disclosures. One of them is that I'm a co-founder of a company, but that bears no relevance to the talk today. I also need to mention that I did a fellowship with Peter Belawski, who is the author of the Reflux Symptom Index and also of the Reflux Finding Score. So that might bias a little bit of what I'm talking about today. So these are the points we're going to be discussing today. I'm really a passionate scholar in the history of ENT, and actually I'll be the chair-elect of the Historical Society of the Academy this coming year. So I really think it is important to get a historical perspective on laryngopharyngeal reflux as a first step. Next, we'll be talking about controversies in laryngopharyngeal reflux diagnosis, and then talk about some of the updates in diagnosis and some of the updates in management. So again, I'm going to be starting with a little bit of a historical review. So in 1972, the first mention of acid laryngitis occurred in the literature by Delahunty in Australia. At the time, Delahunty was postulating a possible role for reflux in laryngeal disease. He described it very similarly to what we described laryngopharyngeal reflux even today, as a hyperplastic heaping of the interarytenoid tissue with inflammation and edema of the posterior third of the vocal cords. And there was also a risk of possible granulation tissue found at the posterior glottis. So very similar to the definition of today. And at the time, Delahunty was thinking that acid was potentially the cause of chronic irritation in some patients who came with symptoms of vague laryngeal inflammation. And it is not until 1991, really, that reflux becomes more en vogue or more the fashion with Jamie Kaufman's trialogical thesis. At the time, Jamie Kaufman is postulating that ENT and GI patients have very different manifestations of reflux. She's postulating also at the time that the study of laryngopharyngeal reflux needs to be done with a double probe pH monitor. Unlike the GI monitoring of reflux, which occurs with a single pH probe that's placed 5 centimeters above the lower esophageal sphincter. At the time, Jamie followed more than 200 patients with different manifestations of ENT pathologies, and she found the highest yield of abnormal pharyngeal reflux in patients who had laryngeal cancer and airway stenosis. So that was a very big finding, because basically Jamie was making the claim that potentially laryngopharyngeal reflux was the cause of really bad pathology in the larynx, including cancer and airway stenosis, which are both needing emergent treatment. It is also really interesting to look at the timing of when Jamie Kaufman's triological thesis was published, which was in 1991. And that is shortly after the PPI came onto the market, both in Europe and in the United States. In 1995, we have the first consensus conference on laryngopharyngeal reflux that was organized again by Jamie Kaufman. And that was interestingly also sponsored by Astra-Merck, which was at the time the maker of omeprazole, or the first commercialized version of a proton pump inhibitor. And I'm sorry, when I say PPI, that means proton pump inhibitor. Let me know if you have any questions about some of the terms I use. So basically, this first consensus statement was really about the definition of the classical presentation of laryngopharyngeal reflux, and also a list of the diagnostic armamentarium that needs to be used to diagnose laryngopharyngeal reflux. And a lot of it really persisted through time and included a comprehensive history, a complete head and neck examination, laryngoscopy, 24-hour double pH probe, monitoring, also consideration of an esophagram, and a therapeutic trial of proton pump inhibitors. In 2001, we have the first score that really looks at the objective findings on laryngoscopy of laryngopharyngeal reflux. This was devised by Peter Belawski while he was doing his fellowship training under Jamie Kaufman. And basically, Peter Belawski defined a set of physical findings on laryngoscopy that are highly associated with reflux. And he basically validated this tool using a pH probe that was a single pH probe in the esophagus that correlated findings of physical findings in the larynx with the presence of gastroesophageal reflux. So the pH probe was placed in the lower, close to the lower esophageal sphincter. So you can see here the reflux finding score that a lot of people still use nowadays to evaluate for symptoms of laryngopharyngeal reflux. Some of you may be very familiar with them. That includes subglottic edema, ventricular obliteration, erythema and swelling, diffuse edema of the larynx, also pachydermia or posterior commissure hypertrophy, granuloma formation over the vocal process, and thick endolaryngeal mucus. A score of more than 11 is suggestive of laryngopharyngeal reflux. A year later, Peter Belawski devises the reflux symptom index. So the reflux symptom index is really more of a patient-measured outcome, and basically it asks about symptoms of hoarseness, throat clearing, cough, and heartburn to create a composite score, whereby a reflux symptom index of more than 13 is suggestive of laryngopharyngeal reflux. And again, this tool is validated with a pH probe study, again, using a single esophageal sensor that's placed close to the lower esophageal sphincter. Okay, and then in 2002, the American Academy of Otolaryngology creates its first official position statement on laryngopharyngeal reflux. So at that time, again, Jamie Kaufman was a very active proponent of this new disease category, and claimed that laryngopharyngeal reflux is a distinct entity from gastroesophageal reflux disease, with less than 40% of patients with LPR who have concurrent heartburn symptoms are the classic symptoms of gastroesophageal reflux disease. And the claim was that the diagnosis may be based on not only symptoms, but also laryngeal findings or double pH testing. However, the real gold standard is the double pH probe test, which was at the time really promoted as the definitive way to diagnose laryngopharyngeal reflux. The claim also at the time of this first statement was that the majority of patients with laryngopharyngeal reflux will require at least twice daily dosing of proton pump inhibitor. And in some cases, it is necessary to try both proton pump inhibitor and H2 blockers. Up to today, the American Academy of Otolaryngology has maintained these claims about laryngopharyngeal reflux. This position statement was adopted in 2006 and it was reaffirmed in 2013, and there hasn't been any new updates since. So in the early 2000s, we see that laryngopharyngeal reflux becomes all the rage within ENT, and it is thought to be associated with the plethora of pathology that we find within otolaryngology, from head and neck cancer to causes of sinusitis, rhinitis, otitis media, you name it, reflux is the cause. And then in 2010, we start seeing a huge backlash against laryngopharyngeal reflux. And this happens as there is more and more consideration about the economic impact of laryngopharyngeal reflux, and the numbers are really staggering because the symptoms of laryngopharyngeal reflux are so vague that they could actually be affecting up to 60% of the US population. And at the time, in the 2010s, a lot of authors are noticing that there is an increasing number of visits to otolaryngologists and gastroenterologists because of LPR, but also an increasing number of prescriptions for PPIs that are leading to a huge burden of cost in treating these patients with LPR. About 10% of these patients with LPR are being sent to ENT for further evaluation by their primary care physicians. And Altman looked at some of the economic impact of prescription of PPI and all the management of LPR, and noticed that there was a 14 times increase in PPI prescription from the 1990s to the early 2000s. And because the treatment for LPR is twice daily PPI for usually more than 2 months, there was a huge increase in PPI treatment in these patients and a huge economic cost. In addition, both ENTs and GI specialists are involved in the treatment of LPR. So we're looking at subspecialists who are seeing patients with pretty vague symptoms and doing very invasive tests and seeing these patients repeatedly for invasive tests, leading to a 5.6 times higher cost in treating LPR compared to GERD. And it is actually estimated that the US economic burden associated with LPR is $52 billion a year, which is actually about the same, if not a little bit more, than the annual cost of cancer care in the US alone. So, and then the issue is that only about half of the patients who get treated with extensive courses of PPI and a lot of diagnostic tests are reporting some improvement. And that's despite the huge amount of money that gets spent on LPR. So the controversy about laryngopharyngeal reflux remains today. And really what I want you to get out of this lecture today is that at the heart of the problem with LPR is that up to today, we do not have a gold standard for diagnosis. And that remains the main issue with LPR, because we have no way of really measuring outcomes of our treatments for these patients because we do not have that gold standard. And for instance, symptom assessment has been found repeatedly to be not a reliable measure of, not a reliable way of diagnosing patients with LPR. And that's the problem, is that the symptoms often overlap with other conditions that can inflame the larynx. So history, or the history that you take from patients, has not been proven to be reliable for accurate diagnosis of laryngopharyngeal reflux. And in fact, cough, globus pharyngeus, throat clearing, dysphonia are present in many other forms of laryngeal illnesses. And it is very hard to really make out what is LPR and what could be caused by something else. Studies have tried to correlate the reflux symptom index with the pH probe findings, but there has been no overlap found besides the initial studies that were used to validate the reflux symptom index. Studies have also used the reflux symptom index to judge response to therapy with PPI, but they have not found it helpful in clinical practice because many patients do not seem to find improvement in their symptoms with our regular management of LPR. And the history of that can be suspicious for LPR is not really conclusive for a diagnosis of LPR. So history is not, or the reflux symptom index is not very helpful. It cannot be the gold standard for diagnosis of LPR. Now, can we use laryngoscopy then as the gold standard for diagnosis of LPR? No, the studies have also, again, repeatedly shown that laryngopharyngeal reflux findings, including the reflux finding score, are not reliable for diagnosis of laryngopharyngeal reflux. There is indeed poor inter and intra-rater reliability, and there is no correlation of the reflux finding score with pharyngeal pH testing, for instance. There is also no correlation of the reflux finding score with PPI response. And also there seems to be basically an increased risk of diagnosing laryngopharyngeal reflux if you're using a flexible laryngoscope as opposed to a rigid stroboscope because of the different quality of the imaging that is obtained. Now, an issue also is that we get a little bit tunnel vision when we assign a diagnosis of laryngopharyngeal reflux to a patient. And what often happens is that, for instance, general ENT will diagnose a patient with laryngopharyngeal reflux and really get focused on that diagnosis and try to find ways of treating it. But unfortunately, they often do not send these patients to their colleagues in laryngology who can perform stroboscopy and actually find laryngeal pathologies that are causing the patient's symptoms and that are not reflux related. I am just going to show you 3 examples of patients who were referred to me in my laryngology practice with a diagnosis of laryngopharyngeal reflux and who did not improve with prolonged treatment on PPI. This is the first patient. This is a 50-year-old woman with a long history of tobacco use, who was treated for her dysphonia and throat clearing with PPI, and basically did not find any improvement. You may recognize on her stroboscopy that she actually has Ranke's edema. Here is another patient who was referred to my practice with a presumed diagnosis of laryngopharyngeal reflux, and again, a prolonged treatment with PPI and no improvement. I'm sorry, this one doesn't have sound. But as you may notice, this patient actually has a little polyp on their left vocal cord that is causing their dysphonia, throat clearing, and throat discomfort. Here is another patient, again, treated this time by their primary care physician for 3 months with proton pump inhibitors for worsening dysphonia. And this is the finding. You can notice that there is a lesion at the anterior commissure and decreased mucosal wave at that location on stroboscopy. And on office biopsy of the laryngeal lesion, it was found to be a squamous cell carcinoma. So again, this is really important also to take out from today's lecture, is that do not make sure that laryngopharyngeal reflux is your diagnosis of exclusion. Do not get focused on it and to the detriment of other possible diagnoses. And if you're unsure, always think about consulting a colleague in laryngology who can perform stroboscopy. So now, is empiric treatment with PPI a possible way of diagnosing laryngopharyngeal reflux? The problem is that if you remember, Jamie Kaufman noted that about 40% of patients who present with laryngopharyngeal reflux may not be PPI responders and are not having the typical symptoms of gastroesophageal reflux disease. And there has been no significant difference in multiple randomized controlled trials between a treatment with PPI and placebo in the treatment of laryngopharyngeal reflux. Now, there are a little bit of there's a little bit of divergent evidence. Some randomized controlled trials are actually finding that PPIs are helpful compared to placebo, and some other randomized controlled trials are not finding that that's the case. And probably what is differentiating this conclusion is that potentially some groups may be missing other diagnoses that are not LPR related and misattributing the diagnosis of LPR so much that the patients that they are recruiting for their studies may not be typical patients with LPR and may not be PPI responders. So currently, it is unclear whether there is really a diagnostic value to PPI treatment, to empiric PPI treatment, but that might still be our best tool today. And then another point of controversy is ambulatory pH testing, because there is no clear agreement on the type of probe that needs to be used for pH testing in patients with laryngopharyngeal reflux. It is also unclear what would be the best location of the pH probe or the impedance probe used for diagnosis. The double pH probe has been found to be unreliable with an adequate sensitivity, but a very poor specificity. And indeed, in a systematic review of 11 studies using the 24-hour double pH probe with one probe at the lower esophageal sphincter and one at the upper esophageal sphincter, it was found that there was no significant difference of pharyngeal reflux between patients with LPR and normal control. There was also another study that found that patients with laryngopharyngeal reflux and no response to PPI did not have abnormal pharyngeal or esophageal pH impedance off or on therapy. Therefore, laryngopharyngeal reflux is probably unlikely in many of those patients who get tested with pH testing. And then finally, there's currently no consensus on whether to perform esophageal pH monitoring on or off PPI. I will, towards the end of the talk, present one algorithm that I think will be helpful in our current setting that will discuss whether or not to use pH monitoring on or off PPI. So with all that I discussed so far, you might be wondering how to manage laryngopharyngeal reflux and where to go from here, because history has been showing that this entity is really hard to define and hard to diagnose because we currently do not have a very strong gold standard for diagnosis. Well, there is some reason for hope. One of them is new technology, and you may have heard of the Restek nasopharyngeal probe. That is a dedicated pharyngeal probe that is made by a company in California, and that is designed to function in the open space of the pharynx without drying. And basically, the Restek probe will measure pH only, both in liquid and in aerosolized droplets. It does not provide information on non-acid reflux because it does not have impedance measurement. And currently, it's using normative values with a pH threshold of 5.5 while the patient is upright, and a pH of 5.0 while the patient is supine. Restek used prior to laryngopharyngeal reflux treatment may actually improve patients' compliance because they have a stronger belief that they may have laryngopharyngeal reflux based on these objective findings. And Restek may predict response to PPI based on the thresholds that are defined. However, there is no recent study. There's a recent study from Northwestern University that found poor correlation on Restek pH measures and LPR symptoms. So maybe a potential future gold standard, but this needs to be studied further. And we, again, need to be able to find a way to ensure that Restek can objectively determine the presence of laryngopharyngeal reflux or not. How about impedance? Just to make sure that everyone understands the term impedance, impedance is basically the total opposition to current flow between adjacent electrodes on an esophageal probe. So it's basically resistance to electrical flow. So currently, multi-channel intraluminal impedance pHmetry is thought to be potentially a better diagnostic measure of laryngopharyngeal reflux. However, one of the issues with the multi-channel or the double probe pH meter that uses impedance is that while the distal probe is placed 5 centimeters above the lower esophageal sphincter, the upper probe, because of people's different heights, may or not fall within the esophagus lower than the upper esophageal sphincter or above the upper esophageal sphincter, and as a result will provide unreliable measures across individuals. Furthermore, when the upper part of the proximal probe moves during swallow, for instance, it may create pseudo-reflux events that are not reliable for measurements of laryngopharyngeal reflux. There is also currently no international consensus on abnormal impedance measurements, especially in the upper esophageal sphincter. So there is currently no agreement on what an abnormal value would be. And until we have that agreement and that consensus, it is very hard to use this tool for research because different studies will use different values for impedance. There is also no normal value that's defined on a large group of normal controls. So we don't know what normal pharyngeal and upper esophageal impedance would be in normal folks. There is some really interesting research coming out of Vanderbilt University using mucosal impedance. So if you look at the right side of the screen, you see an endoscopic balloons with electrodes on it. And basically, this device for measurement of mucosal impedance is introduced during upper endoscopy and measures directly the impedance of the mucosa of the esophagus, and is able to really accurately determine whether or not there is decreased impedance at the lower esophageal sphincter, which seems to be very highly correlated with the presence of gastroesophageal reflux disease. And it is possible that such mucosal impedance device could be very helpful in the gold standard measurement of laryngopharyngeal reflux. You may have seen increasing research on the value of pepsin and trypsin assays in the diagnosis of laryngopharyngeal reflux. But again, we're maybe a little early in being able to use this chemical testing for diagnosis of laryngopharyngeal reflux because, for instance, it is unclear how to determine the threshold of normal versus abnormal amount of pepsin in the saliva. And there is also mediocre sensitivity and specificity for laryngopharyngeal reflux symptoms. And the current literature on pepsin measurement is very heterogeneous. There are some teams that are using the PEP test, which is a standardized way of measuring pepsin. Some other teams are using their own labs. So we currently don't have a standard way of measuring pepsin, and it is really difficult to come to conclusions. There were, for instance, studies that were suggesting that a strong pepsin assay predicts response to PPI, but I just saw this week that another study showed the opposite, that morning increased pepsin assay in the saliva actually correlates with a decreased response to PPI. So unclear whether pepsin is going to be our solution. And trypsin is only starting to be used currently for LPR diagnosis, and it is very unclear whether it will be more helpful than pepsin. So currently, there is globally within ENT a decrease in pH testing, but a continued use of empiric treatment with PPI for the management and the diagnosis, really, of laryngopharyngeal reflux. And as I mentioned earlier, up to today, the American Academy of Otolaryngology still recommends twice-a-day PPI for 2 months for the diagnosis and management of PPI. And only about 50% of otolaryngologists in the US are currently following these guidelines. And I'm going to explain why use of PPI is really falling out of favor in the US and potentially also globally. And really, the American Academy of Otolaryngology has guidelines that are standing in sharp contrast with the gastroenterology societies, which basically are recommending against the use of PPI if there are no concurrent symptoms of gastroesophageal reflux disease, such as heartburn or regurgitation. And again, it is very important, and that though no studies have really demonstrated very powerfully whether diet and lifestyle change are helpful in the management of laryngopharyngeal reflux disease, there is some indication that lowering the amount of acids in the diet, but also having a more balanced diet and avoidance of a late meal before bedtime are actually helpful in mild laryngopharyngeal reflux and may be good adjunct to other intervention in moderate to severe laryngopharyngeal reflux. One issue, though, with this literature is that a lot of people who write these articles are also writing recipe books for low acid diets, so it is unclear if they might be biased by their other competing interests. So one reason why the use of PPI is falling out of favor is because there are some rising concerns about the potential side effects of proton pump inhibitors. And at least in the United States, there is an increasing number of patients who are very concerned about taking taking proton pump inhibitors and want to avoid them at all costs. Now, the evidence for some of the side effects is not very strong. Most of the evidence that basically is demonstrating that PPIs may not be safe are really based on huge data mining studies that find very weak correlation between the use of PPI and some really concerning side effects. And those include dementia, cardiovascular disease, chronic kidney failure. And really, if you look at the evidence for proton pump inhibitor side effects, the only strong evidence is for three side effects. The first one being acute interstitial nephritis, which is very uncommon. A more common side effect that has been demonstrated with proton pump inhibitor use is B12 deficiency. And then finally, there is an increased finding of fundic or gastric gland polyps, but those are of potentially not really significant, not high significance in pathology or in symptoms in patients with reflux. There is also some growing concern about, for instance, low magnesium or increased risk of fracture, increased risk of C. difficile, and aspiration pneumonia. There is also an FDA warning that potentially PPI could be interfering with the efficacy of Plavix. But a lot of these studies are not really quite confirmed by prospective cohort studies. For instance, there was a recent study that followed a group of patients who were taking PPIs and was looking for risk of fracture and osteoporosis, and they found that that risk was only found in women who were smokers, but none in other patients. So while I was in training with Peter Belowski, we did a survey study with our patients that got recently published, and we looked at what were patients' concerns about PPI use. And we found that the majority of our patients, and that was a clinic in California, were concerned about PPI side effects. And their number one concerns were for cardiovascular disease and bone fractures. Most of these patients got concerned about the side effects from talking to their doctors, their primary care physicians, but also in the US, we see a rising number of articles in the press and also advertising on TV that are basically informing patients of the potential risk of chronic PPI use. So this concern about of PPI and their side effects have not only impacted patients' willingness to be compliant with these medications, but also with laryngologists and general otolaryngologists' interest in prescribing those medications. We performed another survey study, this time looking at practice patterns of general ENTs and laryngologists in prescribing proton pump inhibitors for laryngopharyngeal reflux and gastroesophageal reflux disease. And we found that the majority actually of laryngologists were avoiding PPIs altogether. And their main concern was the potential of osteoporosis in their patient population. And those laryngologists that were still prescribing PPIs were usually doing it for GERD symptoms as opposed to laryngopharyngeal reflux symptoms. So how about anti-reflux surgery? Is this the best way for us currently to manage laryngopharyngeal reflux because PPIs are falling out of favor? Well, again, if you remember the motto of my talk today, The issue is that we do not have a gold standard for diagnosis of laryngopharyngeal reflux. So if we do not have such gold standard, it is very hard to really measure outcomes of reflux surgery and see if it is helping our patients. So for instance, this study by Sadalov looked at whether patients who were singers and had symptoms of LPR were finding relief with laryngopharyngeal reflux, reflux surgery. And they found that though there were some subjective improvements, the reflux finding score was completely unchanged before and after surgery. However, the Demister score, which is an objective way of measuring the pH in the esophagus, was actually improved after the surgery, and there was a decreased need for PPI. But again, you see that because of the lack of a gold standard, it's very hard for us to know whether or not the anti-reflux surgery was helping gastroesophageal reflux or laryngopharyngeal reflux. There is currently interest in alternatives to proton pump inhibitors because of the side effects that I mentioned. And one of the products that is growing in popularity are alginates. Alginates are basically made of natural seaweeds, and the way they function is by creating a thick raft when exposed to the acid environment of the stomach, which mechanically will prevent reflux from the stomach into the esophagus. They have basically no side effects, and they're over-the-counter medication. Some of the brands you may have heard of are Gaviscon, Gaviscon Advance, and more recently, Reflux Gourmet. There is some evidence in the literature that potentially these alginates might be helpful in alleviating some of the symptoms related to laryngopharyngeal reflux. But again, because we don't have a gold standard for diagnosis, it is very hard to really assess whether that's the case. So if you look at, for instance, this double-blind placebo-controlled study that looks at alginates in patients with laryngopharyngeal reflux, they used controversial scores for the RSI. So the RSI would be a normal starting at 13, and they used the value of 10. And then the reflux finding score also should be abnormal starting at 11, and they used the value of 5. So it's unclear whether their study was really that robust because the standard cutoffs that they used are not the standard ones. I think the most promising current algorithm is actually coming from our colleague in gastroenterology. And that algorithm has been called the HAS-BEER score. So HAS-BEER stands for heartburn, asthma, BMI in extraesophageal reflux. And basically, if a patient is presenting with laryngeal symptoms, and you may be concerned they might have some other underlying pathology, you want to make sure that the patient is evaluated by an otolaryngologist with direct laryngoscopy, or potentially also a laryngologist to make sure that you're not missing another subtle finding on stroboscopy. If those exams are normal, then you may want to you want to try the patient on PPI for 8 weeks, and once a day PPI is actually sufficient. If they're getting better, then you want to start trying to wean off the patients from the PPI and help them change their lifestyle to manage their reflux with no medication. However, if they're not getting better with a trial of PPI after 8 weeks, then you want to calculate their HAS-BEER score. And that's a very simple score. You get basically 1 point for heartburn, 1 point for the presence of asthma, and 1 point for a BMI of more than 25. What that tells you is whether you have a high pretest probability for reflux or a low pretest probability for reflux. So let's say you have a high HAS-BEER score. That basically means that you are at very high risk of having reflux. And so at that point, you actually want to do impedance pH testing and consider actually the double probe pH test, impedance pH test on PPI treatment. If, however, your pretest probability is low and you have a low Hasbier score of less than 2, then you want to do regular esophageal pH testing of proton pump inhibitor for 7 to 10 days. And basically, you will determine whether or not the patient who's presenting has reflux. So now, let's say the tests are negative, then you actually want to send the patient back to ENT for further evaluation, because they might have some other finding on their laryngoscopy or their stroboscopy. But let's say the pH test or the impedance pH test is positive, then you want to optimize the PPI therapy and actually at this point even consider anti-reflux surgery. I think the Hasbier score is probably the best way for us to think about an algorithm for treatment of laryngopharyngeal reflux at this point, in the presence of, or actually in the absence of a gold standard for the diagnosis. And then just because it is contemporary, is LPR actually making COVID symptoms worse? There was an article that came out a couple of months ago from Wuhan that claimed that patients who had laryngopharyngeal reflux disease may actually have worse symptoms of COVID-19 and yet higher risk. And I just want you to take a look at this abstract, and I really hope that after the lecture today, you will really take these type of studies with a grain of salt. If you remember, again, I cannot repeat that enough, because we do not have a gold standard for the diagnosis of laryngopharyngeal reflux, and we know that the reflux symptom index is actually extremely unreliable in diagnosing LPR. A study that is looking at symptoms of URI and is making the claim that patients with those symptoms are actually having laryngopharyngeal reflux based on an elevated RSI score is very doubtful and is probably not a very significant study. So I really hope that when you look at the literature after this lecture today, you will be more critical and really understand that the lack of gold standard makes a lot of these studies questionable. So in conclusion, there is persistent limitation in the diagnosis and outcome measurement of laryngopharyngeal reflux, which leads to questionable measurements of treatment effects and difficulties with directing patients to the appropriate therapy. Proton pump inhibitors, at least in the United States, are really falling out of favor because they're extremely costly and potentially have side effects that our patients do not want to be exposed to. There's some reason for hope for potential gold standard for diagnosis of LPR that includes the Restec pH probe, salivary pepsin, and mucosal impedance, but we still need a lot more data to really validate these tools and see whether they're really helpful to objectively measure the presence of laryngopharyngeal reflux. We may want to consider redefining the diagnostic criteria and also the therapeutic management of laryngopharyngeal reflux. And as you saw, potentially the Hasbier score could be a new way for us to think about LPR and work in conjunction with our colleagues from gastroenterology in really directing our patients to the correct management. And finally, if nothing is working with your patients and if they're having persistent symptoms, do remember to send them to your colleagues in laryngology, because stroboscopy can provide additional tools for diagnosis of laryngeal pathologies that you may miss on regular flexible laryngoscopy. And with that note, I will conclude, and I'm happy to answer any of your questions.
Thank you very much. Really informative lecture. Enjoyed it really well. So there is the, if you could see the chat line, Dr. Amo,
Yes.
Yes, so if you could just ask you to scroll through this chat line and see if you could answer some of the question. And in the meantime, you might see some windows popping up because I'm going to be doing like 2 polls asking people some questions. So please don't worry about the polls. Go
Sure,
ahead.
sounds good.
Thank
Okay, so in all cases of LPR, laryngoscopy or stroboscopy is a must to rule out any pathology before labeling LPR. Absolutely, that is extremely important. Laryngopharyngeal reflux must remain a diagnosis of exclusion, and we must make sure that there is no other underlying illness. I really took the perspective of a laryngologist and a general ENT during this lecture, but also always remember that if your patients are having extraesophageal reflux symptoms, it is very important for them to also get screened by a GI doctor for esophagitis, Barrett's esophagus, and esophageal cancer. Because esophageal cancer is actually on the rise in most countries and has been associated with gastroesophageal reflux disease, I would say the most important thing to do for these patients is to make sure that they do not have any underlying esophageal pathology, because that can be potentially serious. And also something that I forgot to emphasize during the lecture today was that LPR actually has not been found to be associated with leukoplakia of the larynx, with airway stenosis, and laryngeal cancer. And though those were initial claims in the 1990s, including by Jamie Kaufman, those have not been demonstrated with further studies. So really what we care about in reflux is esophageal health, because we know that reflux causes cancer of the esophagus. So treating laryngopharyngeal reflux, if everything is normal, is more of a holistic treatment. You want to make sure your patients are getting better. But right now, there's no evidence that laryngopharyngeal reflux is associated with really bad illnesses.
Dr. Ramon, I don't know if you see the results, but what's your, I know it's different from one community to another, one country to another, but what's your, like in the US, do you think it's overdiagnosed or underdiagnosed by ENT doctors?
Unfortunately, from current survey studies and also from the practice patterns that I see within my community, it continues to be overdiagnosed. And the problem is that oftentimes patients are being seen by general ENTs who do not have stroboscopy. And stroboscopy really helps you see some laryngeal pathologies that are not seen, for instance, on fiber optic laryngoscopy. And the problem is that these patients get continually treated with PPI and don't get relief. So it is it continues to be overdiagnosed. And I can only speak of the current state in the US. I'm not really sure about the countries that you all are from, but at least in the US, it continues to be overdiagnosed.
Well, the audience certainly shares your perception by 61 to 40% that it is overdiagnosed. Yeah. Can I ask you to continue on with if there's any other chat questions?
Sure. What is your take on prescribing prokinetics along with PPIs? That's a really good question. So there is a growing amount of evidence on the value of prokinetics in treating gastroesophageal reflux disease. And in the case of LPR, it really has been found to be helpful in patients who have an increased BMI. So if your patient is obese and they're not finding relief with PPIs alone, you want to actually try some of the prokinetics to see if that helps them. May I know the duration of PPI based on current guidelines before labeling as non-responder, please? So currently, if we think back about the Hasbier score, I think that's a very good algorithm to think about when treating these patients. Usually you want to treat your patients with 2 months of PPI, and instead of twice a day, once a day PPI is sufficient to treat the patients. And usually 20 milligrams is a sufficient amount. Some patients with smaller body habitus may be okay with 10 milligrams of PPI daily. So I would go ahead and treat your patients for 2 months and see if they respond. And if they do not respond, then refer back to the Hasbier score and go from there. So when should we combine PPI with a prokinetic? So I think I answered that. So, obese patients, and any tool to diagnose pepsinogen in the throat as acid activates this pepsin. Yes, so you can actually take biopsies of the pharynx. That is a little uncomfortable, and most labs will actually look at presence of pepsin. So that can be, whether it is in the pepsinogen or pepsin form, doesn't really matter. It can be diagnosed within most general labs. And there's also the PEP test now that is not so costly that you can also use, which comes in a swab form and is a little less uncomfortable than biopsies. So can H. pylori have a role in laryngopharyngeal reflux? Potentially, but again, the problem is that we do not have a gold standard for the diagnosis of laryngopharyngeal reflux, unlike the diagnosis of H. pylori colonization. So it is, as a result, it is very hard to know whether or not it has a role. Currently, there is no strong evidence that it might be the case, but that would be something to definitely look at in more detail in the future. In all cases of supposed LPR, I always ask gastroenterology colleagues to do an upper GI endoscopy to rule out pathology. Yes, exactly. I think that is a very important thing to do. Again, reflux causes esophageal cancer. It does not cause laryngeal cancer as far as we know with our current evidence. So checking the health of the esophagus is really primordial. How long would you give prokinetics for? I would say if your patient is obese and you want to try them out on PPI with prokinetics, a trial of 2 months would be a good amount of time. And if they're not getting better, then it's time to get them tested for presence of reflux.
Dr. Amand, I don't know if do you see the results of our second poll?
Yes.
Okay, so the first, do you think it's too difficult that the findings on regular nasopharyngoscopy, of reflux, is it too difficult to observe even in severe conditions? Do you disagree with that statement, or you agree with that statement?
So I would, the current evidence actually goes against the use of the reflux finding score in diagnosing laryngopharyngeal reflux. But obviously, in or a clinic setting, if we have a very high suspicion, if the patient is, for instance, reporting reflux, more classical symptoms of reflux, along with symptoms of laryngopharyngeal reflux disease, and you see the classic signs of LPR on your laryngoscopy, then I would agree that potentially you would have a higher suspicion for LPR, and you may want to treat them with PPI. But the current evidence is really going against RFS, or the reflux finding score, as a reliable way of determining the presence of LPR. I know it's not very satisfying because that is not what we experience clinically, but really through studies, RFS has been found to not be reliable for the same rater looking at different patients, or different raters looking at the same patients. So the evidence really works against this.
I have to tell you that first, the group is sort of agreeing with your statements, and I have to tell you personally, I find it very, very hard to tell one situation from another. I know that they keep pointing to pictures and stuff, and I look closer and I can't see anything. But thank
Yeah.
you very much. This is a great talk and very, very pertinent to our clinical practice. So enjoyed having you and thank you for taking the time with
Thank
us.
you very much. My pleasure. Nice meeting you all.
All right. Take care.
Bye-bye.
So, bye-bye. So tomorrow, please, you're going to be 2 sessions. The first one is going to be in the morning. It's going to be from Cape Town, University of Cape Town, and it's going to be about I think evaluation of perinatal airway obstruction. It's going to be at 10 o'clock Dubai time, and in the evening we're going to have Dr. Oliver Donker, who's a real authority cochlear implants, talk about intraoperative electrocardiography. I think you're gonna, even if you don't do cochlear implants, you enjoy his talk because he will really dive into some of the exciting stuff that's happening in cochlear implantation. So thank you all. Have a nice evening and take care.